There is a concept called cutoff order that tells you, I have this specific frequency at this value, and that's your cutoff. Then don't take anything beyond that. For example, here is the spectrum. Let's say this is the background area, and this is the patient data along with some noise. And this area is the high frequency noise. This is exactly how your frequencies look. Now, if you want to use a 0.2 cutoff, it means that at the frequency of 0.2 cutoff, stop your spectrum there. Don't take anything at 0.4. Stop. There. And at 0.6, stop. There. So, for you, I call this the cutoff. The higher your cutoff is, the more high frequency content you are allowing. If your cutoff value is high, you should expect the noise to increase, right? So, that's what I want to say. Now, what about the order? The order represents the steepness or the stepping of the curve shape. What does that mean? It refers to the slope of the curve. The more you increase the order, just come here and ask. This is an image of a lever, and this is a spline. This is a nuclear imaging image. Now you are using another filter called the Medzi filter. This filter has a cutoff of 1, and this filter has a cutoff of 0.5. Okay? Well, in the context of this discussion, it is important to understand that the phrase 1 cutoff means that you are considered as an input. In comparison, this image is considered a blessing over that one. So, when your cutoff is high, what did you do? You entered the image and effectively reduced the noise present in your image. The noise present in your image has increased. There is another thing called order. The higher its value, the more it steps up the curve, giving you more resolution or more contrast in the image. The values for cutoff and order are fixed in the protocol during post-processing in a specific examination. For example, I use Butterworth with a cutoff of 0.5 and an order of 5 or 6. The adjustment of cutoff and order depends on the image and what you want to see in it. Filters play a very important role, as we mentioned, in removing the noise present in the image and smoothing it out in nuclear imaging. The role of the filter is somewhat more apparent in CT and X-ray imaging. In X-ray, you click on a specific setting to work on, while in nuclear imaging, you control these values, changing the cutoff and order, and it gives you a certain shape in front of you. And you can say, yes, apply this shape or don't apply it. I don't want to go too deep into this topic, but I will understand the concepts of order and cutoff and their relation to the filters present here. For example, this is without any filter because the image is very noisy since it captured the entire range of frequencies present in the background of the image and the object itself in the noise. So, I want to apply a cutoff. Let me remove this part. I don't want it, so the noise should decrease. Now let me remove this part. The noise started to decrease more. Now let me remove this part. Do you see the noise? You tell me what? I reduced your cutoff. So you are removing the high frequencies that represent what? The noise that is present and the background, right, doctors? What's up, doctor? Is it at the expense of the universe? Of course, it's at the expense of the universe. Every time I look, doctor, a little bit of resolution doesn't hurt. I mean, if you have a little bit of noise, it doesn't hurt. You need the resolution. You should do optimization. For example, when you move in the CT, you see the child's image is very smooth. This doesn't happen sometimes when a small child comes in for a CT abdomen. You find the liver is very smooth, the image is very smooth as it should be. Is this a diagnostic image for you? Or does it need to be a bit rough? It should have some sharpness and resolution. That's what I'm talking about. When you increase the smoothing too much, the contrast decreases. So you have to choose the settings and order that give you the best image. For me, as Islam, for example, this would be very optimum to work on. But someone else might work on this, but it's very noisy. It's noisy, but there's no data in it. You took a very smooth image. So you removed the frequencies of the data from the patient. This is fine. The frequency game happens in post-processing, of course. After the image is taken, work begins on it, and the analysis starts. Is that clear, doctors? I hope you are not. You are tired there. I will talk about physics now. I will take some simple things as well as some natural things, so that you don't feel that the world is far away. We just finished discussing the topic of filters and the things we were talking about and the role of this discussion in our work. We take some simple points. We mentioned that there are two types of imaging, planar and SPECT. For example, if you want to take a picture, you inject the patient with a dose. You want to see the thyroid, you want to see the kidneys, and you want to take an anterior image, 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 anterior image. There is a substance called DMSA, which binds with proteins and targets the cortex of the kidneys. I want to see what this examination reveals. I want to observe the kidney morphology present. Does it have scars? Are there any issues? Is there any part of the cortex not functioning? I want to take images, for example, by injecting the patients and then imaging after a few hours to prevent leakage of the substance, capturing a static image in front of me. I start by identifying areas with scars and those that are not absorbing the radioactive material. How does this work? Simply put, the patient is positioned and a static image is taken. It is called a static image because the patient is still and the head is fixed. You detect the photons coming in. For example, this image takes about 5 minutes, and every minute you perform a certain count. This count is then translated into an image. In summary, the work we've discussed doesn't have any issues. For me, this story is like, for example, this image here. Notice that the background is black. This is the original image, not the inverted one. The left kidney and the right kidney are like this. You have taken an oblique image at a certain angle. All of this is a static image. This is also a static image for you, for example. This is an examination. If you want to take a picture like this, add the thyroid knife here in the thyroid area. The phone is inserted in this way, and the design should have the phone close to the device to reduce the receiver and enhance the receiver. The receiver is, of course, a very important factor that affects the imaging. This will show if there is any metal or problem with the patient, and the crystal or head is brought closer. There is a crystal that takes an anterior image, and the head takes a posterior image of the thyroid. We do not need a multidimensional image as it operates one of the detectors. This monitor displays the image in this way and plays it, taking a picture of the thyroid, for example. It starts counting counts, and you can adjust your counts based on the type of isotope you are working with and the matrix you are using. The most common matrix, for example, is the 128x128 matrix size, especially in cases of planar imaging or static imaging. You might need the 256 matrix in this case because you will need to increase the count or the scan time significantly. So you can either move or give high activity to compensate for the loss that will occur or the resolution or noise that will be present. For example, these are images of the thyroid. You have the thyroid filled with radioactive material. This coordinated image shows that this part is cold, meaning this part did not take up radioactive material. So I call it a cold nodule. This is an example of Graves' disease. This case is multinodular, toxic multinodular. Here, for instance, there is a part that is one of the two glands, meaning one of them is completely absent. And this is an example of thyroiditis. Here, it is not taking any uptake, it is present, and this is called the hot nodule, meaning it is taking up and has high activity compared to the rest of the thyroid. So, for example, you all can see this information. This is a thyroid scan. All of this is static imaging. Are there any issues with the images? Look at the video images that I just uploaded.
Red. Yes. The first was fully met. It was located underneath in the posterior head, not in one area. It is one underneath that operates the one above, which has no relation to the one below. The second thing is how. Regarding the count rate that I calculate, it determines the count rate with the adjustment, of course, which is the number of photons with photon energy. And what about you?
How many notes do you take? The notes that are entered are the collected notes, which are comprehensive in energy and without the second one. I mean, you say, I want this image, for example, this image to calculate the notes. It has a certain relationship. First, the translator must be challenged, and it should discuss the value of the pixel. These protocols are actually ready to begin. What happens in them? It states that the examination of the thyroid will take, for example, 6 million counts, or 5 million counts, or 5,000 kilo counts. For instance, the $5 million yield an image that is considered accepted. These values can be calculated physically, but if we delve into the details, it can be overwhelming. Firstly, these values are essentially provided by the company itself, which supplies you with fixed protocols. There are guidelines, for example, from the European Association of Nuclear Medicine, or the SN Mills Society of Nuclear Medicine and Nuclear Imaging, both American and European, which publish guidelines in the field of nuclear medicine. These guidelines dictate how you should inject the patient, account for dose, work with matrix size, and set scan time. All this information is included in your guidelines. So when you come to adjust the protocol, you take these values and work with them accordingly.
So that's the point.
So what is the idea, Dr. Hani? What happens is that you don't really adhere to the guidelines. For example, you have a patient who is fatty and their dose is low and the image is not good. So if you want to get a good image, what do? The scan time or dose adjustment is indeed happening daily, as I mentioned. There is no specific protocol, but you work on these parameters and modify them because the situation is truly variable. For instance, a patient might be delayed in the process. After injecting the patient with a dose, for example, in the thyroid, they might be brought in after half an hour. You might have many cases, and this patient could come in after 4 or 5 hours. So what will happen to the activity? It will decrease due to the washout from the patient, leading to a lower count. Therefore, you will have to increase the scan time instead of redoing the patient. To compensate, you need to increase the sensitivity or the collected counts to provide an appropriate image quality. It includes, essentially, your count represents how many photons the crystal detects, irrespective of whether the energy is outside the spectrum or inside the spectrum. It doesn't matter to you of whether. That's it. Now, there is another type, which is dynamic. Dynamic is the most famous examination included in renal scans. The renal scan aims to determine the glomerular filtration rate, GFR, for example, for both kidneys or for split function kidneys. Then a substance called MAC3 or a substance called DTBA is injected. DTBA is a contrast agent or a substance named DTBA. This becomes a label with technetium. I gave it a hydrophilic substance that loves water. Therefore, when it is injected, it behaves like water, exiting the kidneys and entering the ureter, then going to the bladder. What happens? This patient needs dynamics. What does dynamics mean? It means that the patient starts lying on the table and begins to work with the lower head to get closer to the kidneys instead of working from above. This means that if it works anteriorly, of course, except in certain cases where there is hardship in the kidneys or something, but it works posteriorly. This is the first frame. The substance here must enter the kidneys after, which the kidneys, for example, the bladder, must contain low activity. Then the kidneys start to function in this manner, in this sequence. This is the timeline until it reaches this point. What will happen? This is the first segment, and this is the last segment for you. This is the last segment. Here the bladder lights up, and the kidneys are added here, and the background here is less visible. You see this background compared to this background, which was high. Why? Because your activity is just being excreted from the body, it enters the kidneys, and then the bladder starts to light up. So a complete excretion has occurred. This examination takes about 25 to 30 minutes on the machine, where you check the patient dynamics. Why? Because before I inject, I start my acquisition process to take small frames every 10 seconds, capturing images repeatedly. So you start to gather these frames, and you have what? You have this kidney and this kidney. This is the left kidney, and this is the right kidney. In this context, the depiction of the city is entirely contrary to what one might typically expect. The focus or main subject is also presented in a way that is completely opposite to the norm. I am curious to understand how the numerical count changes as time progresses. What does the change in count over time signify? Essentially, it signifies the state of the kidneys at the initial point in time, known as time zero. The image of the city serves as a metaphor for underlying changes that occur beneath the surface, reflecting a broader narrative of transformation. The subject, being opposite, challenges preconceived notions and invites re-evaluation of what is considered standard. The count is not merely a number, but represents dynamic shifts over time, offering insights into underlying processes. Understanding these changes is crucial as it provides a window into initial conditions and their evolution, particularly concerning the kidneys, vital organs responsible for filtering waste and maintaining bodily homeostasis. At time zero, we establish a baseline from which all subsequent changes are measured, allowing for comprehensive analysis of progression and implications. The count here was low. The radioactive substance hadn't reached it yet. After that, the count starts to rise until it reaches its peak. Then it begins to decrease, leading to a washout effect over time during my 20-minute period. So this is the time and the count, or total counts, which is the collective curve that I call the time activity curve. Okay, activity curve. If this kidney has a stone blocking its output, what will happen? You will take the measurement, and then you will find the curve doing this. Because in this case, the kidney hasn't had an output due to a blockage, so the substance won't go down. Now, if one kidney has an output and the other doesn't, you will get two curves, one for each kidney. So you can determine the function of each kidney separately, which is very important, especially in organ transplantation. If the curve looks like this, it means that the function of the kidney is weak, as the kidney itself hasn't taken up the radioactive substance. Therefore, this curve represents the function of the kidney, from which you can derive the glomerular filtration rate and the specific function equations, of course. You have exactly every function for each kidney, how much the glomerular filtration rate is for each kidney, and here's your percentage. This is the uptake. And this is in case the kidney is normal like this, or if my kidney is normal, then it undergoes oxygenation. Is this clear, nurse? Is there any problem with this? Okay. This is the time when its shape can be more clear, and this is the time when its shape can be more clear, and this is the time when its shape can be more clear, and this is the time when its shape can be more clear, and this is the time when its shape can be more clear, and this is the time when its shape can be more clear, and this is the time when its shape can be more clear, and this is the time when its shape can be more clear, and this is the time when its shape can be more clear, and this is the time when it can be. The split function, kidney counts, kidney depth, and all these parameters for the left and right kidney and the total begin to be diagnosed based on this information. This is the region of interest that is drawn, and this is the background. It must take the raw background as a reference for its calculations. In the dynamic examinations, there is a test called the multi-gated acquisition technique. What does this wave do? As you can see here, this image shows the left ventricle and the right ventricle. In the multi-gated acquisition technique, a substance called pyrophosphate is injected. This bioactive substance is first injected into the patient's body, and it goes to the red blood cells, concentrating in them and remaining present. After that, free technetium is injected, which means it is not bound to any chemical substance. The bioactive substance is waiting for technetium to enter. The radioactive substance was injected, and then it was held in place, and they did a scan. The radioactive substance ended up in the heart, which lights up in this way. The entire heart lights up like this. This examination is done dynamically, meaning something called first pass is performed, where the patient is positioned on the machine itself, and it connects to the ECG. This is one of the tests used to assess the heart muscle through systole and diastole. As you can see in the curve here, it shows the area specific to the ventricle, and the ventricle moves, and you can see how it was moving. During systole and diastole, if we consider systole, it starts calculating something called systolic volume, and it begins to calculate the maximum dilation that will occur in the left ventricle, resulting in something called end diastolic volume. Then, of course, the equation for the ejection fraction is applied, which gives the percentage of the ejection fraction for the left ventricle. This represents one of the most accurate examinations for determining the ejection fraction in relation to the left ventricle, and it has developed into one of the most precise tests for assessing the function of the left ventricle. By taking the region of interest, as I mentioned, it starts to give you this curve. This curve represents the end diastolic volume, ED, and the end systolic volume, which is the lowest volume for the left ventricle. It begins to show you the change in volume over time, indicating what is happening here. No for you, and your hands start to change with time. What is he doing? Here, he starts to take, because this gesture is depicting SG, meaning it is depicting a Gettel. As we will talk a little bit more about the Gettel topic, you will find, for example, with you, give the BQRST after that. For example, you will find in the BQR, so you will find here R in the SG, and here R. The entire distance from R to R is divided into frames called the cardiac cycle. These frames can be 8 frames or 16 frames. Most people usually work with 8 frames. So what are these 8 frames? At the R point, as you all know, there is contractility, which is the system. And then relaxation occurs, followed by diastole, and then systole. So what do? You image this patient, for example, over a specific time period, which could be, let's say, 5 minutes. So how many R points are there in those 5 minutes? This is or like this. Thus, for example, it is from R to R, and its duration is not long but very short. It takes a picture here, takes a picture here, and takes a picture here, 8 images from R to R, and decides from the second R2 R, 8 more images. 1, 2, 3, 4, 5. So what do I have at each R? For example, this examination lasts 5 minutes. And in those 5 minutes, there are 100 R. So how many images of R do I have in this situation, in this movement of the heart? I have 100 images, right?